Okay, you'll see here on our screen, everyone, that we really wanted to promote the National Health Science Conference for 2023, and it'll be in October. We'll be in Seattle, Washington. The pre-conference will be on Monday, October 16th, and then the regular conference will be all day Tuesday and Wednesday and a half day on Thursday. So it's a little different from the usual pattern. We had been the Tuesday through Friday, and this year will be Monday through Thursday. We hope that you'll consider joining us. This is really how we met Colin. We heard such good things about his presentation through those that were at the conference, as well as in the evaluation summary. He was mentioned and his presentation was mentioned. And so that's how we invited him to be a part of our Wednesday webinar spring series. On our website, and you'll see there, healthscienceconsortium.org. And right on the homepage, it'll say for more information about the conference. On that page, there is the registration that is open. Within the registration, there's a hotel link for the Westin, where we'll be right downtown. There is also a request to attend letter. We call it our courage letter that teachers can use if they're submitting a request to attend, and it has all the costs in there. It's in a Word document you can download and make it your own, but it gives you a framework of justifying why it would be a great opportunity for you for professional development. And then there is a general agenda there that we know many of you need to attach to a request to attend. So with that, I just wanted really to mention that because that's how we met Colin. And you too can get famous like Colin as a presenter, and we might invite you to be a part of our webinar series. With that, Colin, I'm going to pass you the microphone. And I do know that you said you'd be willing to take questions within the chat. And also there may be a little bit of time at the end. We understand that you have been a classroom teacher for about 4 years there in Idaho, teaching EMR for 11th graders, I think you said, and then EMT for your 12th graders. Thank you so much for being here, and we look forward to your presentation.
Okay, awesome. Well, happy to help. Let me do the screen share here. Let's see, does that look good?
It does.
All right, so briefly, real quick, because there is unfortunately a lot to cover in an hour, but I am a certified flight paramedic, and I'm also a special operations medic in 19 Special Forces Group out of Utah. And so this medical, I have a decent medical background. So, and also being a teacher, I do a lot of teaching in the military as well. So this should be a pretty good fit. So I'm actually going to start a 1 hour stopwatch right here. So I know people's time is important, and so I'm not gonna try to go over that hour. I'll try to leave a little bit of time at the end if we can, just for questions. And if something does come up, you are welcome to ask in the chat or whatever. And I'll try to answer the best of my ability. So it's all good if you're just curious immediately. If you have a question, it's all good. Okay, so this is going to be a shock review. So this is going to cover all the various types of shock that are out there, and kind of the up-to-date treatment. And unfortunately, a lot of it is going to be hospital level treatment. But the big thing for us as like working in EMS, or even just health science educators, or even just teachers, is that it's about recognition. And so we need to be able to recognize these red flags of these different types of shock, and then kind of be able to get them to the right place quickly. And some of these cases, there's things you can do immediately that will make a difference. And sometimes it's just getting them to the hospital quickly. So our cardiovascular system is going to be a heart, our vasculature, and our blood, so our arteries and veins and capillaries and all that fun stuff. And so this will keep coming up because all the various types of shock that are out there, they affect one of these three. And so I also will sometimes compare this, what you see here, to like a golf course with the sprinkler system. So just in that, our heart or our body has these three components. A golf course is going to have a pump, it's going to have water, and it's going to have the sprinkler pipes that water the grass. And if the grass doesn't get water, then the grass is going to die. And so that's the same thing with us, just with our blood. So some of our vocab here is going to be perfusion. So I'll kind of use this word throughout the presentation. And so it's going to be adequate blood flow. So if you say it's a perfused organ or a perfused tissue, that just means it has adequate blood flow, and you can have that exchange. And so another word I'm sure we've all heard of is homeostasis. And that's going to be, they're kind of the same thing. So homeostasis means that metabolic demands are being met and the body can exist without any sort of issue. So shock is a state of hypoperfusion or inadequate tissue perfusion. And so now you're not going to have that good blood flow for various reasons. And then the body will start to basically fall apart over time. And then our job is to kind of get in there, recognize it early, and catch it before it gets to that irreversible shock. So why does it matter? So why does shock and everything we're talking about matter? So in part, carbon dioxide can actually build up, and that can actually make our blood more acidic and actually start to damage our tissues. And our brain, our body actually evaluates carbon dioxide levels as opposed to oxygen levels in our brain, our brainstem that monitors how we should be breathing. So carbon dioxide is actually a very important thing to pay attention to. But then on the flip side of that, there's also impaired delivery of oxygen. And there's that thing, if you guys remember from high school, there's that Krebs cycle thing. And it has to do with aerobic or versus anaerobic respiration and just how the cellular metabolism basically. And if it's aerobic, there's oxygen involved, things go a lot better. And now if it's anaerobic, well, there's really a big reduction in the energy production of our cells. And there's even more waste products built up. So the real Krebs cycle, unfortunately, is this. I have had to, every time it comes up, I have to kind of relearn it. People do tend to forget it, but it is what we're talking about, just kind of that cellular level and how each cell works. So that cellular waste product can build up, and it's gonna make the blood a little bit more acidic. And over time, it can result in death. So we'll talk about, this kind of comes up a few times through the presentation. It's about shock progression. So the initial insult happens, whatever that may be. That may be an injury, maybe like a gunshot wound or a spinal cord injury or a bee sting or whatever may happen. And then your body tries to fix it. It doesn't immediately give up. And so your body's going to do things to compensate for the shock. So your body's going to kind of go into like overdrive, work really hard, and try to maintain that homeostasis, maintain that perfusion, because our body knows we need to perfuse the whole body. So it's going to do what it can, and then at a certain point in time, if we don't fix it, then it goes into decompensated shock, and that's when things get real bad. So the idea is catch it early and hope that we can kind of work with the body and keep it in that compensated shock territory. So just as a reminder, so of our perfusion, so it's not just the oxygen, it's all, and carbon dioxide, it's also some nutrients like blood sugar and our hormones, and all those mechanisms have to work to get our different chemicals that are in our body around the body. And once that suffers, you can have tissue damage, organ damage, and eventually death. So just a quick explanation about kind of how sensitive we are. So unfortunately, we are a very Goldilocks creature, right? Our happy zone here is 7.35 to 7.45 on the pH scale. And it doesn't really take much to go one way or the other. And one of the fastest ways to do that is even our respiratory drive. So if we start breathing weird, I would look at pH levels. And so anytime you have a patient who maybe has an injury of some sort and you notice their breathing pattern is getting a little weird, usually there's something deeper going on. It's usually not even with the lungs. It may be some sort of blood pH level that it's doing. So our waste product is that carbon dioxide. We breathe that out. So that's also like measured as an acid in our body. And so we're going to be breathing faster to try to breathe out that CO2 and try to fix our pH thing. And so our brain is constantly assessing our CO2 levels, and it breathes differently to try and fix that. So when our body goes in a state of shock and our body kind of goes into hyperdrive and tries to fix things, the two main systems that are going to be used is our lungs, and that's literally just trying to breathe. Now that works very quickly, as in it goes to work quickly, but it takes a while for effects to be seen. And so you may not note it like right away as they start to breathe weird. And then the other system is our kidneys. And these are really effective, but it can take even longer to do this. And so when we talk about blood pressure, and the reason why blood pressure is so important is if that blood pressure dips too low, the kidneys will actually no longer get that blood flow, no longer get that perfusion. So now the kidneys effectively go offline. So now your primary generator of trying to fix your whatever may be happening in your body, your kidneys are trying to fix that. And if that blood pressure falls off, well, the kidneys shut off, and now you're in a lot of trouble. And so the idea is to hopefully try to get things solved before it comes to this decompensated shock where now the organs aren't getting blood flow, and it really just kind of escalates. So for that compensation that the body will do to try to correct the imbalance is going to increase the heart rate. So think about if you had a sprinkler system on a golf course, and for whatever reason, you've lost a lot of water in your sprinkler system. Well, you still want to get that water out to all the areas on the grass. So you might turn that pump up. And then not only if you had the power to, you would also kind of make it a stronger pumping action, right? So our body will do the same thing. And then peripheral vasoconstriction. So vasodilation, which we're going to talk a lot about in this lecture. So vasodilation is everything kind of gets bigger and spreads out. Vasoconstriction, everything tightens up and gets more narrow. So our body is going to kind of try to narrow things up to raise that internal, really fluid volume inside our pipes, so to speak. So that's why maybe if you see someone who's in a bad state of shock or who's has some decent injury, they might look pale. And that's because the body realizes, I don't need blood flow to my skin. I don't need all this warm blood flow out to my arms. I actually need it inside my arteries. I need it to do its job and try to do this homeostasis thing. So that's why you may see weird skin color changes. And that's the body trying to compensate for the damage that it's sustained. So just as a reminder, in us, we got the pump, which is our heart, set of pipes, which is all these different kind of vasculature, and then our content, which is our blood. And blood is like the best thing, obviously, where we're getting away from IV fluids in EMS to a degree. We'll talk about it a little bit in our hypovolemic shock part of this, but blood transfusions are kind of the new deal. We realized way too late that pumping a body full of IV fluid, it maintains pressure, but that's all it does. IV fluid doesn't carry oxygen. It doesn't carry blood sugar. It doesn't do any of that. And so all we're doing is kind of artificially inflating the pressure, and it's not really benefiting our patients. Not to mention, a lot of IV fluid is actually kind of acidic. So the patient's already acidic, and now we're giving him more acidic fluid. And so we are in the process of kind of rewriting some of those protocols. And the old days of 2 large bore IVs wide open, just get the fluid in there, we are really pulling back from that. That turns out was not a great idea. So talk about our cardiovascular system, where it's all right here. So you got your lungs, you got your heart, and then it's that kind of on the bottom and the top there. It's that systemic circulation. It's at the cellular level. It's that exchange of nutrients. And then I also put this up here because we're going to talk about cardiogenic shock, which has a few different causes. And we'll talk about where damage starts to occur, and then some of the symptoms you're going to see kind of based on this map here. So as mentioned before, basically any kind of shock is going to go down to an issue with one of these 3 components. So something will happen to our heart, something will happen to our blood vessels, or something will happen to our blood. And so it's kind of figuring out what exactly happened. So just as a reminder for how we measure perfusion, it's going to be that blood pressure. So the systolic is on top, and that's going to be the peak pressure inside the vasculature during that contraction phase of the heart. Then the diastolic is going to be that relaxation phase. So it's kind of both the peak and the bottom of the pressure inside our arteries. And when we have those numbers, we can kind of figure out how the body is doing and kind of how that perfusion is going. So normal is like a perfect blood pressure is like 120 over 80. And then the higher you go, kind of the worse it can get. So 120 over 80 is ideal. Elevated is kind of like that 120, 130. And then some people will call this stage 1, or they'll call it pre-hypertension. They'll call that systolic like 130 to 139. And then really once you've hit 140 systolic or higher, or 90 on the diastolic, then you're kind of looking at your actual hypertension. And of course, above that, all the way up to like 180, we actually are going to call that a hypertensive emergency. And that does need to be evaluated and treated somehow, because our pipes are really meant for that 120 over 80. That's what our arteries and capillaries, that's just what makes sense for us. So if all of a sudden we are consistently at 180 or even 140 for a long period of time, it's going to do damage and things are going to start to go wrong. It's just like in our water pipes inside a house or inside that sprinkler system. If it just has that whatever water pressure that it's kind of designed for and it works well, that's great. But if you start upping that pressure, eventually that system is going to break down, because it's just not meant to have that high of blood pressure or water pressure the whole time. So these are going to be what we're talking about for like the types of shock. And so some of us have probably heard of some of these, and maybe other of these are new. And so we're going to start with our pump failure and then kind of work down. So pump failure, it's going to be that heart failure of some sort. So it's going to be cardiogenic shock. And I just remember like cardiogenic, like generating from the cardiac, or obstructive causes. And this is kind of a weird gray area, technically still considered pump failure because the heart pumping action is something's wrong with it. However, in the obstructive cases, the heart is actually fine, but something is obstructing it. And so luckily, this is one of those things in medicine where they actually named it correctly. So obstructive, just think of something in the way. And so that's a tension pneumothorax, cardiac tamponade, or pulmonary embolism. And so we'll go kind of through those. Then you have your, I guess I'm looking at the table on the right. Then you have your poor vessel function, and that's just distributive shock. So the way I remember that is like distribution. So you got a good pump and you got the blood or the water, but it's just the distribution of it is a little messed up. So you have like a pipe issue. And then the last one, probably the easiest to understand, is that low fluid volume or hypovolemic, and that could have hemorrhagic causes or your non-hemorrhagic causes. So we'll kind of talk about all the different parts of that, all the different types of shock, and then eventually we'll go through the treatments. And like I said, some you can do a lot at right there on the sidewalk. Others, you kind of need a doctor. You might even need surgery, that kind of thing. So cardiogenic shock, the easiest example of this is going to be like a heart attack. And you can see in that picture there. So you have a clot, or you can maybe have that plaque buildup in the coronary vessels. And it'll have that occlusion on there. And so as the blood is flowing through the heart, and once the heart goes without blood supply, it tends to suffer pretty quickly. Our muscles can go without blood supply for actually a few hours without any major issue, whereas the cardiac tissue is much more sensitive, and it starts to let you know real quick if you're having a cardiac or coronary blood flow issue. And so cardiogenic shock. So the body is unable to meet the demands of the body because something is wrong with the heart. And the perfect example of that would be like a heart attack, like you just saw in that previous slide. But there can be a few other things that with the heart tissue itself, valvular disorders, things like that. And some of the effects of that is, well, a large section of that heart muscle may no longer move very well, or may not move at all, because it's gone enough time without that perfusion that the tissue just starts to die. You can also have dangerous heart rhythms, or like dangerous heart beats. So ventricular tachycardia, so it beats really, really fast, or ventricular fibrillation, which is when the heart more or less looks like it has a seizure. It's ineffective. It's just kind of just moving erratically. And about 70% of our patients who have heart attacks are actually in a state of ventricular fibrillation. So no blood is being moved. The heart is just kind of spasming. And then you have SVT, which is basically a heart rate that's so fast, you're almost not pushing enough blood either, because once you're beating like 200 beats a minute, I mean, how much blood are we really pushing if it's going 200 beats, right? Or on the opposite end, you might have a very slow heart rate because it just depends where that damage is, or even a heart block where the electricity is sending through the heart and it hits that dead or dying tissue and it just kind of stops. And so the pump is obviously a very sensitive organ, a very important organ. And so cardiogenic shock is when something is wrong with the pump tissue itself. So you could have some of these things, like I mentioned before, your septal defects, your arrhythmias, things like that maybe you were born with, perhaps, that maybe showed up later. Or you can have your external causes, which are going to be your pneumothorax, your tamponade, and your pulmonary embolism. And so on those three, the pump is actually okay, but it's something is in the way that's preventing it. So at the end of the day, it's the same effect. You are not getting a good homeostasis. You are not getting that perfusion, but it's because something is in the way preventing that heart from doing its job. So I know some of these slides are a little busy, but you know, I'm not trying to have a 150 slide PowerPoint either. So cardiogenic shock, we're talking about. So what might we see in our patients? And then you could actually see these symptoms actually pretty quickly because that heart is such an important organ. So if you remember back to that picture of like the heart and the lungs and the blood flow, so depending on your symptoms, you can almost figure out what side of the heart is being affected by the symptoms you're seeing. So a left-sided heart failure will cause pulmonary edema. So what that just means is like fluid and kind of swelling in the lungs. And that is because blood and fluid is backing up into the lungs. So what happens is your blood will go through right atrium, right ventricle, into the lungs, do its thing. It'll circle back. It'll try to drop into the left atrium and then to the rest of the body. But because the left side of the heart is failing, it's just a traffic jam. So think about, I'm gonna say Houston or Atlanta, some of those cities you've heard about where there's really bad traffic, right? So that all the red blood cells are coming in and they hit that traffic jam, and it starts to back up in the vasculature, and the lungs are right there. So it starts to back up into the lungs. So you might see that pulmonary edema, or you might even hear it. They might start coughing, or maybe if they're laying on their back, that fluid will actually spread out and they'll say, I can't lay down, I cough too much. Now, conversely, on the other side is your right-sided heart failure, but the exact same situation. So blood goes up to your head, does its perfusion up there. Now it's going down to the heart and it hits that traffic jam. And now, same idea, it backs up. So you're going to see these jugular veins will start to get really big because that blood has nowhere to go. And so you'll see it go up there. And then you might even see some fluid build up in your feet for the same issue. Your blood's coming up from your lower body, hits the traffic jam, and then just starts backing up. So if it's a cardiac condition, you always want to think about like lung issues, and you can think about blood flow and look at that jugular vein, and then even look down at their feet, and that might tell you what's going on. You're going to have some of that cool, clammy, pale skin, and that's because of that vasoconstriction. So the body knows something is wrong, and so it's going to pull blood in from the exterior, and it's going to try to put it in the vessels and try and fix this problem. And you're also going to see that increased breathing rate, and that's probably because there's some sort of acidosis building up, and it's gonna want to fix that. Now, cardiomegaly is a side effect of this cardiogenic shock. However, this is maybe for someone who has long-term heart failure, like your congestive heart failure folks. And this is something where they have congestive heart failure and it kind of just gets worse over time. Like they can survive with it. Maybe they take some medications. And it just, if they don't make the changes they need to make, it can lead to cardiomegaly. And as you can see on X-ray there, pretty obvious how that's kind of builds up over time. And the heart is a muscle just like your bicep. And if it just has to beat through that blood and it's really struggling because of heart failure, and so the parts of the heart that are still working effectively, they got to work overtime to maintain that perfusion, maintain that homeostasis. The tissue will actually grow. And so it's just, if you have someone who says, yes, I have congestive heart failure, just be aware that maybe their heart is pretty enlarged. And, you know, we're kind of packed tightly in here. And an enlarged heart like that is obviously just going to make things worse. So that's more of just like a long-term effect of your cardiovascular compromise. So, and this is just another review of some of the signs and symptoms you might see with that right-sided versus left-sided heart failure. And it's really think about a traffic highway flow, right? Like where's traffic going to go? If there's a car accident, where does it back up into? And so that's left-sided versus right-sided. Okay, so now we'll get kind of a little bit more complicated, and these are actually more traumatic most of the time. Pulmonary embolism may or may not be, but usually a cardiac tamponade or tension pneumothorax is going to have a traumatic aspect to it. So it's some sort of obstruction that is kind of in the way. So the heart is trying to beat and something is not letting it. So the pericardium is, so our heart has this little plastic bag that's wrapped around it, and there's a little bit of fluid in there, and that kind of just helps the pump be a pump. And unfortunately, it's a pretty tight little plastic bag there. So if we get extra fluid built up in that little plastic bag, the heart starts to suffer pretty quickly. And so the heart is trying to beat, because there is a mechanical pumping action. So the heart actually does fill with blood and then squeeze that blood out. It does that. And so now if it's surrounded, if it's kind of being crushed by this extra fluid, the heart is trying to beat, and it's effectively underwater. It just can't do it. So you might see that with a severe chest injury. That can be things like blunt trauma can even do that. Heart attack can lead to that. Pericarditis and kind of infection that can lead to some of that fluid leaking out. And even an aortic dissection, which just means kind of an internal bleed that fills up that pericardial sac. And so in medicine, usually if there's three things that happen commonly, we're just going to call that a triad, and some doctor gets to put his name on it. So Beck's triad is the three symptoms that have been noticed repetitively for these kind of patients. And it's going to be low blood pressure, that jugular vein distension, and muffled heart sound. So low blood pressure, because that heart is not beating very well. So they just can't maintain that perfusion. Jugular vein distension, like we mentioned, that traffic jam up in the neck. And then muffled heart sound. So you might try and listen to that lub-dub sound on the chest, and it effectively just sounds like it's underwater. And in a way it is, because it's kind of being drowned by this extra fluid. So the heart is going to try and beat faster to fix that issue. They're going to be pretty anxious about it, obviously, because something's definitely wrong inside. They might even have some sharp pain that can radiate to different places, shortness of breath, and a weak pulse. And it's a weak pulse because the heart is just can't really beat the way it's supposed to. So here's a nice little picture. I am still a 7-year-old at heart, so pictures always do it for me. So basically it looks like that. You just have a lot of fluid built up, and that poor heart just can't really pump that well through that extra fluid. And then you have your little Beck's triad thing there as well. Okay, tension pneumothorax. So this one is actually, I think people are a little bit more into this just because it's been in movies and Grey's Anatomy and different movies and TV shows like that. But basically, if you have, and the best way to, I guess, get one of these is a gunshot wound or a knife wound into the chest. So some sort of open chest injury. Our diaphragm creates that negative pressure. So air is just going to come in. So when that diaphragm contracts and creates that negative vacuum kind of in this box here, that air is just going to get sucked right in. And it's going to literally form this air bubble inside the chest. And until you cover that thing, there's nothing to stop it. The air, it's physics, it's path of least resistance. Air is just going to keep on coming in. So as you can see there, you're going to see the exact same signs and symptoms almost, because the heart is trying to do its mechanical pumping action, but this big old air bubble is in the way. And so now the heart kind of can't do it. Now, tracheal deviation, I put that as a late sign because that is a very common sign. Like people are aware of that. Like, oh yeah, the trachea, instead of being midline on our neck here, it will actually shift over. So that is something that can happen. I just want to point out that is a very late sign. And if you do see tracheal deviation in a trauma patient, he is near death for lots of reasons. And so tracheal deviation is a sign, but it's down the road. So just because someone may have an open chest wound and you don't see that tracheal deviation yet, I wouldn't relax yet, right? So that's a very late sign. So here is once again, a cartoon of it. And if you can just look at that picture, and once you see that trachea deviate as pictured, there's a lot of air built up in there. So it's not only is it crushing the heart and the rest of some of the tissues in your mediastinum, that lung is also not not doing anything either. So now that person's down to one lung, and it might even get squished against the other side of the wall. So you're having a heart issue, you're having a lung issue, you're having a diaphragm issue. So these pneumothoraxes can become a real big problem. And so the terminology is like a pneumothorax and a tension pneumothorax. And the biggest difference there is a pneumothorax is just air in your thoracic cavity. So if I take a syringe with 20 cc's of air, put it in there, cool, you have a pneumothorax. A tension pneumothorax is, once you see in the picture there, it's creating tension within the system, and it's actually causing that cardiogenic shock. So you're going to start to see the blood pressure fall off because there's just a huge balloon full of air in there. And then the last one that obstructs that flow and kind of obstruct the mechanical pumping action is a pulmonary embolism. And so that is a clot, usually somewhere else in the leg, and it'll kind of break off and then just be circulating around the body. Now, your body is in a constant state of breaking down clots. So unfortunately, it's just kind of a toss of the dice. If you have a clot down there, maybe that clot breaks free, and maybe as it's traveling, your body can get in there and it can break that clot down, and you won't even know you ever had a clot. You'll have no idea. Or if it's a big enough clot, it'll just keep going. It'll get stuck somewhere in the lungs. And then once again, that is that traffic jam issue. Blood flow will get restricted, and it will back up into the heart. And now the heart is trying to pump in this super, traffic jam that is caused by this clot in the heart. And so this is a very bad example, a very severe example, but that is almost a complete cast, right, of the pulmonary vasculature. And so that was a clot. You can almost see the carina up there and kind of in the center where it branches out. And that clot just led to more and more clots. And it just basically filled up the entire lungs vasculature with clotted blood. And as you can tell, there's really no way to survive that. When these pulmonary embolisms, unfortunately, can go from bad to worse very quickly. Whereas a heart attack, it's kind of about location. So it's like maybe you have an obstruction in a small vessel, and it just like takes a while for the damage to show up, and they have a little bit of chest pain, and then it kind of goes away, and then it feels better, and it can get a little weird. Whereas a pulmonary embolism is pretty much like once that clot shows up, you're in trouble. So this one actually is a very fast progression. Once that clot's there, it starts to snowball pretty quick. But what you're going to see is shortness of breath, chest pain. The heartbeat's going to start to become irregular from all that backing up that's happening. They might even cough up blood, and once again, that low blood pressure. So it just as a reminder, shock equals low blood pressure. So low that you're actually not getting blood flow everywhere where you need it. So, okay, so then moving on to the next area of shock, it's going to be the distribution of fluid. So in this one, in a perfect world, the pump is doing just fine. You have all the blood you need, that's fine. But now there's an issue with the pipes inside. So the four main times we're going to see this is a severe infection called sepsis, which is actually kind of a major concern right now in hospitals. An allergic reaction, so that's one we're probably the most familiar with. A spinal cord injury, usually a high spinal cord injury, and then a psychological reaction, which technically is a type of shock because it is a vasodilation that involves a person kind of like passing out. Luckily it's a little different though, because usually when they go horizontal, the body can kind of tighten back up and then they're fine. Whereas these other types of injuries, are not going to get better in 30 seconds, like the psychogenic will. So septic shock, it's been a major problem for probably as long as humans have been alive. And it continues to be an issue in hospitals. So there's a little flow chart there. And so basically it just starts with some sort of local infection that then goes systemic, and it just kind of builds. And really once it hits that bloodstream, then it really just spreads out, because now the entire, your blood, your water, right, is infected, and it will just continue to infect other parts of the body, and it will lead to organ dysfunction and then eventually death. And so not only will your vessels will also kind of dilate a little bit, but also they're just going to leak the fluid. The toxins generated by the bacteria just start destroying that tissue, and it's not able to work well. So it's like, imagine a sprinkler system analogy. Imagine you put some sort of like acid inside your pipes, right? And that acid's going through there. It's just going to be damaging the pipes. It's going to be leaking through, and you're probably not going to have a very good sprinkler system if you have a bunch of acid in your pipes. So this is an article. We are not going to go over that. That would be mean. But I did highlight some of the kind of the important components of this. So I did you guys a favor and I read it for you. Interestingly enough, so Machiavelli, so he was a pretty prolific writer back in the day. This is how he described septic shock. So, obviously this has been a struggle for humanity for, thousands of years. And this is in the 1400s, this is how they kind of addressed it. And so severe sepsis is pretty prevalent. And so it's pretty common. And that last bullet point is pretty scary because you got to get on those antibiotics quick. So this is one of those types of shock where there's not much we can do pre-hospital on the sidewalk, but they need a hospital and they need those antibiotics because they need that help. Because in the war between like our white blood cells and the bacteria is winning, and the bacteria will just keep winning until they kill the host, right? So at this point, they need that some medical like hospital evaluation. So these are some of the vocab for it. It's not super important, you're aware of these, but it's just kind of, once again, it's that progression. So you kind of have, so you have SIRS, so it's kind of that inflammatory response. So it's basically saying that the body realizes this isn't just some little area of redness on a cut or something. This is actually becoming a more serious infection. So it starts with SIRS, and then it's going to go to sepsis, and that's when it reaches the bloodstream. And now it's going to go systemic, and it's going to start kind of really snowballing and doing more damage. And then eventually that can build to septic shock. And that is when you're going to have the true shock of it, which is going to be the low blood pressure, the lack of perfusion, and then you have all like the cascade of the waste products building up and everything else. So it has to be recognized quickly, because once a person gets to that septic shock territory, the bacteria has kind of taken over at that point, and it's much harder to kind of beat that back at that point. So if there's an infection that looks pretty serious, we got to get that person in. And so once again, just a nice little picture of kind of how that looks. And some of the signs and symptoms, I know this kind of looks like your typical infection you might have. However, the 2 points, or I guess 3 points, are a little different. Is you're going to be acute confusion. So if someone's pretty sick, or they have some sort of infection on their arm or something, and all of a sudden they're a little altered mental status, that's a major red flag. If their urine levels are lower than normal, that shows that they are severely dehydrated. They're probably getting some of that fluid leaking. Hypotension and rash, and that rash also kind of shows that it's like a systemic full body infection. So see, these are some of the things you're going to see. You're also going to see that like really pale skin, that pulling the blood flow back into the vasculature. And I have seen this in people in their 20s who had some sort of internal infection, and it just kind of overpowered the body's defense mechanisms and kind of took over. So this is another one. As you can tell, you can see right there on that thing there, it says 2020 Sepsis Alliance. So they are really pushing this sepsis control thing because it's a major problem. And at the end, we'll talk about some of the barriers to treatment. And so septic shock is kind of in its own world because there's some unique barriers to treatment that none of the other issues or none of the other types of shock have to deal with. Okay, anaphylactic shock. So I think we're familiar with this one just from movies and whatever else. It is a body kind of overreacting and causing your low blood pressure and some of your respiratory complaints. So that can happen from some people's vaccines or certain medications. It can happen from stings. That's what we think of, like the bee sting, or maybe like peanuts or something from ingestion, or even inhalation. Some people are really sensitive to even the latex powder. Sometimes can put someone into a state of anaphylactic shock. So the body detects that kind of offending agent, and then it just freaks out, and it's going to dump a bunch of things that the body's like trying to help, but it kind of just overdoes it. So it's going to release some histamines and some leukotrienes, and it's going to cause that widespread vasodilation. Some of that increased permeability, just like septic shock, some fluid leakage. And it's also going to cause some airway muscle constriction, so that airway might be starting to tighten up. So once again, pictures, all pictures. It's a little flow chart of just kind of what happens inside the body. So allergen or an antigen affects the body. Your body's antibodies go to work, and then it just kind of overdoes it, and it releases too much histamine and some of your other like defense chemicals, resulting in your anaphylactic shock and some of your airway issues. So we are used to thinking about our anaphylactic shock or anaphylaxis as your respiratory complaint and your low blood pressure, maybe some hives. And so, and that all that is true. However, I'm just pointing out here that there actually are some other things as well. So it's not just like the big three we think of. There also could be some GI complaints and some other things like that. So it could be a little bit deeper than just that. This is a busy slide, so we're not gonna spend a lot of time on it, but it's just, once again, proving my point that it's not just kind of your respiratory issue. It could be all sorts of other things, including that GI component that we don't typically think of when we think of our anaphylactic shock. Okay, neurogenic shock. This is a pretty sad one because there's not much we can do about this as far as treatment. So usually a result of a high spinal cord injury, but it could happen from tumors, certain brain conditions, things like that. Really, anytime there's an issue with the spinal cord, an obstruction to the spinal cord, and you can see on the right on that picture there, those vessels are going to dilate. So our spinal cord is that information superhighway. So our brain is constantly telling our body to vasoconstrict, vasodilate, hey, pop your hair up, hey, sweat, hey, do this, hey, do that. Well, once you have that spinal cord injury, that information superhighway no longer works. So your brain is saying to do, telling your body to do all these things, and the information just never gets there. And so as a result, everything just dilates out. Everything, because there's no one in charge anymore, basically. And our default state is just to kind of dilate out. So it's kind of that primary and the follow-on secondary injuries that lead to the loss of sympathetic tone. So we're talking about our parasympathetic and our sympathetic nervous systems, which kind of do this. And so this is like damage to the nervous system. And it's pretty serious, and it happens usually right away. And so they're going to have that drop in blood pressure because everything dilates out. Their heart rate can get pretty slow, and they're not going to be able to regulate temperature at all, because all those commands of our body saying, hey, tighten up, hey, dilate, hey, do this, it just dead ends right there where the injury is. So none of that information gets there. So you might actually have really flushed, warm skin because our body is telling us to tighten up and it just doesn't. And so you might feel that, oh, they're really warm down here in their lower extremities. And that could be because the body is just flushing out. And kind of like we've already said. So some of the temperature issues, slow heart rate, and some of that low blood pressure, AKA shock. Okay, so psychogenic shock. Syncope is the word for just fainting. So they might see some bad news. They might get some bad news or see something kind of violent or bloody or triggering, we'll say. They just kind of pass out. I just had it happen to me in class last week with a student. So it happens. It's usually what we say is non-life threatening because they will fall over, and then usually they'll kind of recover, and that's it. Assuming that it's not some other issue like a brain aneurysm or something like that. Okay, yeah, so the treatment, I guess we'll talk about treatment at the end. It's really just like hang out with them for a second, don't have them stand up, and they're usually pretty fine. So that is a type of shock, but it's not really as serious because they recover pretty quick. And then your hypovolemic shock. So that is just hypovolume, so low volume. It can happen from hemorrhagic, so blood loss, or going to be your non-hemorrhagic causes like your diarrhea, vomiting, dehydration. Now, your non-hemorrhagic causes of hypovolemic shock, you're going to see that more in like babies and infants, things like that, who have some sort of illness. So, okay, let's see here. There we go. Okay, didn't want to move for me. All right, so hypovolemic shock signs and symptoms. Well, anxiety and agitation. That mental status is going to be one of the first things you see. So they're going to get kind of anxious, kind of agitated, because the body can tell that something's wrong. Cool, clammy skin. It's pulling that blood back. Confusion, decreased urinary output, general weakness, rapid breathing. So these are all signs and symptoms that something is not right with the body. So just as a reminder, because we'll kind of move on to some of our treatments. Compensation, your body's trying to fix it. It's going to overdrive to do what it can to turn the ship around, so to speak. However, decompensated is when it just kind of falls off a cliff. The body has worked, and it's just out of fuel. It just can't do it anymore. And then you'll see that blood pressure fall. So usually that blood pressure may be the last thing. And if you think about it, once you've lost your blood pressure, what else is there to lose, right? There's really nothing, there's nothing left for your body to do other than kind of just give up. So blood pressure is usually the last thing we're going to see change. Okay, just another little slide there of like what we'll see with compensation and what we'll see with our decompensated. And in fact, sometimes they will decompensate so bad that they will no longer have a radial pulse because the body says, you know what, I don't need blood flow to my fingers. I don't need blood flow to my toes. I need blood in here. I need to keep this brain going and the heart and the lungs going. So you might, and of course they will look very pale, and you can try to find that radial pulse, and you may not have it. And then you check that carotid. If they have a carotid but they don't have a radial, that's usually indicative that they have really gone decompensated shock, and the body's kind of giving up. And it's like, this is the last thing the body can do is pull that blood in and just like hope that somehow, we're going to recover. So again, blood pressure, last thing to change, and expect shock. Really, almost, I would say expect shock or maybe plan for shock. If you got some sort of, multiple severe fractures, multi-system trauma patient, or abdominal chest injury, right? There's a lot of stuff going on there. So that can lead to shock, spinal cord injury, or kind of any of the things we've talked about. So for some of this, for our general kind of guidelines, is going to be control obvious bleeding. We need every drop of blood. So in the event that there is a bleed going on, we got to have that blood inside. So treat all bleeding regardless of kind of what's happening. Now, if you are worried about that spinal cord injury, you're probably going to want to mobilize their spine, because the more movement that spinal cord does, the more damage could occur. So we got to be really careful, really slow it down. If we try to rush through this and just like, all right, just get them on the gurney, get them in the hospital, you could actually make it a lot worse. So it's okay in some of these cases to slow it down a little bit and make sure we're not making that spinal cord injury worse. Try not to give them anything by mouth, because that can lead to vomiting and aspiration. And this place blankets part, hypothermia is a very important component. So since they've lost all this blood, their body is not effectively working anymore. So that temperature regulation piece is not effectively working anymore. So we need to help them out, because their hypothalamus is kind of going haywire with the shock going on. So we need to assist them. Hypothermia can actually be a pretty big killer, especially in the context of a bleed, because hypothermia can alter the way that we clot. So hypothermia is a pretty big deal. Cardiogenic shock treatment. So this is going to be like your classic examples, like a heart attack. Yikes. Not much we can do here. EMTs can push some like nitroglycerin or some aspirin. Paramedics can push a few higher level drugs than that. But I mean, they need a hospital. You cannot really solve a heart attack on the sidewalk. They got to get advanced level treatments. Obstructive shock. So we'll talk about the 3 different types and how you treat that. So increasing cardiac output is the priority here, because the heart is not able to beat. So do what you can. I would say at the higher level, you might push some fluid just to maintain that pressure at this point, because the pump itself is damaged or is unable to pump correctly. Really though, it's going to be surgery or needle pericardial centesis, where they're actually going to put a needle into the chest cavity and they're going to draw all that fluid out. It's a very advanced skill. It is very rarely performed in the field. You're supposed to be ultrasound guided. It's like that kind of thing. So if we have like a blunt chest trauma then you start to see JVD and some of those things, man, they got to go to the hospital right now. They need, bright lights and cold steel, as some people call it. Tension pneumothorax. So this again is kind of an upper level thing. However, it can be addressed in the field, but usually going to be for that like paramedic or above level, or advanced TMT in certain cities. So call for ALS. If you are, even if you're not a medic, if you're not EMT, you can call for try to specify, hey, advanced life support. I see a hole in his chest. That's pretty indicative that there will be some advanced treatment required. And so the treatment there is actually going to take a needle. It used to be a 14 gauge. Now we're kind of switching to a 10 gauge, which is just a crazy needle. And you're going to drop it in one of these 3 locations. We're kind of going back and forth about the best spot. You can look up peer-reviewed journals if you want. There's different arguments about which is better. But the idea is you got that air pocket in there, got to get that air out. That's the only way to solve this problem. So you can drop a needle and then pull it. So you drop a needle with a catheter. You'll pull the needle out, but the catheter will still be in there and the air will escape. If you ever get bored this week and you want to watch a movie, there's a movie called Three Kings with Ice Cube and George Clooney. And there's actually a scene where someone gets shot and they actually do a needle D. And for once, Hollywood actually nailed it. They actually did a pretty good job of showing kind of what that looks like. And you can even watch that clip on YouTube if you kind of just want to see like a more of a aesthetically pleasing version of it, of like how the needle goes in and the air will escape. Pulmonary embolism, man, this is once again, that high level treatment. There's nothing we can really do at our level pre-hospital. They're going to do some clot busting drugs to maybe get in there and kind of break that clot apart, or they may even have to do a surgical removal. And the big thing here with these PEs is, I mean, you got to go. Like you have to get there as quick as possible because it is so internal. There's nothing we can really do until it's like potentially in the OR. So time is everything on PEs. Septic shock. So hospital management required. I mean, you got to give them antibiotics, but long-term, I mean, IV antibiotics. Like this is, it has to be really high-level doctors involved here. Ventilatory support may be necessary because they're dropping off the cliff that bad. So what we can do, keep them warm. I don't know, give IV fluid if you're trained. There's really not much we can do. And then every hospital should have a sepsis team, and their whole job is getting ahead of the sepsis train. So that sepsis, you remember that picture of that arrow? So that sepsis, man, that bacteria, it's trying to do this. It's trying to get down that arrow. And their sepsis team, their idea is to get in there right in the middle and try and turn that thing around. Now, a barrier to treatment, like I said earlier, that's kind of an interesting barrier that other types of shock are not going to have, is this idea of antibiotic resistance. On the right side, you'll see lots of different causes. That is why you cannot buy antibiotics over the counter, because Americans are notoriously, I guess, impatient, as I'll put it nicely. They think, oh, I have a headache, I'll take antibiotic, or should I take this? I don't know, I'll just take it, right? Well, the bacteria kind of can figure that out, and over time can become resistant. And this is a picture I took off the internet, but it was from a hospital, and someone had a Pseudomonas infection, and they gave some antibiotics, and just wasn't really working. So they decided to culture it, and then like, all right, let's see what works. And boom, all those antibiotics were no longer adequately treated that infection. So what they're doing now is we are actually going back from antibiotics that we used in the 60s, and we're actually bringing those back up because those are surprisingly still effective because they haven't been used in 40 years, right? And so this antibiotic resistance is a big issue, and honestly, we're not doing a good job of managing this problem. Obviously, it's a very complex problem, and I think it's going to be a barrier to treatment for a long time. And I've talked to doctors about it, and we're trying, but it's a big deal with not a lot of options. So not much to say about that.
Colin,
Neurogenic shock.
Colin, you have about 5 minutes.
Okay, I think I'm on track. Yeah.
Okay, good.
So neurogenic shock is just going to be treatment, spine boredom. Prevent that spine from moving. They're going to have to go see specialists, maybe surgery if there's something they can do. Otherwise, they might just be paralyzed, and they're going to have to go down that long-term treatment. Anaphylactic shock treatment, hey, EpiPen. We've all seen that. We all probably know someone who has an EpiPen. EpiPen's amazing. It reverses it. So anaphylactic shock is dilation and then constriction up here. EpiPen reverses that. It tightens your vasculature and it expands your lungs. So it's like the perfect reversal agent. So anaphylactic shock, hit them with an EpiPen if they have it. Boom, that'll usually turn it around pretty quick. And so there you go. It's a direct reversal agent for our anaphylaxis. Oops, there you go. Okay, psychogenic treatment. Hey, don't worry about it. I mean, I don't mean to minimize it, but the patients I've seen that have psychogenic shock and they kind of fall over, assuming they didn't fall and hit their head or anything, they're usually fine. I would just say don't let them stand up immediately. because their blood pressure might still be a little wonky. And so like, just kind of sit with them for a second, say, hey, how you doing? Kind of check in with them, check their mental status. If you heard a loud bang, check their body real quick, check their teeth. Like, hey, do you bite your tongue? Which actually is somewhat common when they fall. So let's kind of give their body an assessment. But after a minute or two, if they're feeling good and their mentation's there, no major injuries, they'll be fine. So last one we'll talk about, hypovolemic shock. So control all external bleeding. We need every drop. And then the new thing, like I said before, is that blood transfusion. And if you don't have fresh whole blood, try to do freeze-dried plasma, packed RBCs, cryoprecipitate, like whatever your agency is out there, they need blood. So it's like blood for blood. If a person has lost 500 mils of blood, they got to get 500 mils back in. So, and that is depending on the states you live. Some states are actually, Oklahoma, weirdly enough, Oklahoma is actually kind of ahead of the curve on this, and they are actually doing a lot of whole blood transfusions in the field in the back of an ambulance, which is pretty cool. Idaho is a little bit more delayed. Flight paramedics are already doing that, but some of your typical EMS agencies are still a little afraid because if you do the wrong blood type, bad things can happen. However, it's 2023. I think we figured it out. And if you use O negative, low titer, the transfusion reactions are less than 1%. So it's pretty safe. Busy slide of just what happens to the body. So your body will do these compensation mechanisms, and it will either fix the problem and the body will continue to survive and do well, or it won't. And then you have the bottom side. So it's just the body's doing all these kind of things to like fix the issue. Okay, another busy slide. You can look up these slides if you want, out like on the internet or whatever, of just kind of comparing and contrasting. So cardiogenic shock, you're going to see this, et cetera, et cetera, et cetera. So you can look up some of those. And then I just threw this to make a dig at the VA because that's where I get to my healthcare. So that was a down and dirty. It was like just at an hour, maybe a little bit under. So that I know I was talking fast, and that was a tremendous amount of information for 1 hour, but I didn't want to do like half of the shock types. I didn't think that was right. So I did kind of just zoom through it. But yeah, this is recorded. As you said, it's archived, so you can review it. And then this should be like all over the internet. There's all sorts of things. So if you want further information, it's definitely out there. So with the last minute or two before we hit that hour, is there any questions or comments or anything about the different types of shock and its treatments?
Colin, there was a question, and you might have answered that when you on the last slide or two back. Someone asked if you were going to share the slides, and this may be proprietary and slides that you use over and over again. So don't know if you're willing to share the slides.
Oh, absolutely. I don't care. The way I see it is the more people are aware of this stuff, like the better everyone's going to be, right? So yes, I don't know. I'll probably talk with you, Nancy, about maybe the best way to put it on the website or something. I don't know. But
yeah,
yes,
absolutely. All you need to do